fields, there are three real main ways that a static field will interact with the body. First is magnetic susceptibility. So this is the physical effect that causes metal objects to get dragged into the magnet. And iron has a positive magnetic susceptibility. And interestingly, actually, our bodies all have a negative susceptibility, but obviously much, much smaller. And so we're all diamagnetic. And in fact, this is a daisy that's being levitated above a magnet, rather similar to an MR magnet, but with a much stronger variation in magnetic field. And so all the objects, as they go into the magnet, all human bodies, if they go into the magnet, are actually being slightly repelled by it in exactly the same way as the iron's being sucked in. So that's the first effect. And I'm going to show an effect that actually has in cellular development later on. The other is, as you all know from your GCSE or O-level physics, you get induced currents. If you have something that's conducting, moving a magnetic field, it will induce currents in the body. And this is definitely the case in an MR scanner. As you walk around the MR scanner, you'll get some currents induced in your body. They're of the sort of order of the currents induced in your body where your heart beating, or the surface of your body by your heart beating, they are induced. And the third effect is the Magnetohydrodynamic Effect, which is kind of the reverse of the one above, which is if you've got a conducting fluid moving a magnetic field, you get a force on that fluid. The most likely place for that is at the top of the aortic arch. So as you're lying in the magnet, the field's that way, the blood's flowing across the aortic arch that way, you'll get a force on that fluid. But actually that force doesn't become significant. You get to about 16 Tesla, it's been calculated. And it doesn't produce significant effectively blood flow, blood pressure at 70. Now, these effects do have potential biological effects. There is indication that chemical reaction rates, well, it's definitely the case that some chemical reaction rates can be affected by magnetic fields because basically of the spin states of the electrons. And you might think, well, that's a bad thing for biology, but actually when you put that into a biological context and you look at it in a biological pathway, biochemical pathway, actually it's never the rate-limiting effect. Well, nobody's discovered it to be the rate-limiting effect. However, there are some indications that it's a kind of co-mutagenesis effect with other carcinogens. There's some effects of X-rays seeming to be exacerbated by magnetic fields. This isn't really a problem for MR, because we try not to expose people to what is, apart from possibly PET MR, we don't try not to expose people to X-rays and MR simultaneously. But there is a potential area there. And I think it's important to know there are potential areas, because it kind of puts us out of this realm of MR being safe. You can actually sort of put some boundaries as to safety. I think it makes it easier to talk about. There is some evidence of expression of gene pathways being altered. We know there's some evidence that magnetic fields will affect growth patterns in cartilage. And we've done a lot of work at Nottingham looking at the effects of magnetic fields on sensory effects. So we know magnetic fields will make you feel dizzy if you move in the fields. This is almost certainly due to electric currents induced in your ears. You get metallic taste at high field, moving the field, due to currents induced in your mouth. This is possibly the most sort of definitive effect of a high field, excuse me, a magnetic field on embryo development. This is a frog embryo at 0T and 16T. And you can see at 0T, the third cleavage plane is equatorial, as you would expect. At 16T, it looks like an orange. And this can be explained by that susceptibility effect I was talking about earlier. The differences in the magnetic susceptibility of the cell organelles and the cytoplasm are such that you get little forces, tiny forces on this cell at this early stage of development, these cells in this early stage of development, that cause the cell division to occur in this unstandard fashion. However, despite this, as this animal develops, this is a frog embryo, other biological forces take over and this becomes insignificant, or rather like the effects on chemical reaction rates. It becomes insignificant to the sort of size of other biological forces that take over, and these frogs develop normally. So I feel very confident saying there's no consistent evidence that static fields can harm the fetus to up to, say, 4T, and there's not much evidence about that either way for MR-type exposures. Now we go on to RF heating. So first of all, we need to look at how the RF's deposited in the fetus. There's been quite a lot of work at looking at RF models of the fetus. So the question then is, when you put a person in an MR scanner, how does the RF distribute within the mother and the fetus? And so there have been several models. This is a very biologically a non-standard model of a pregnant woman with increasing gestational ages, and showing the distribution of RF, SAR, within the different organs. And the yellowish coloured line in the middle there is actually the fetus. And so it's showing that basically the fetus receives less SAR, RF, than the mother. And there have been many other studies like this showing similar effects. This is the SAR maps with different field strengths. Interestingly, the RF deposition at high field, 3T, is somewhat less than its lower field within the fetus. The distribution of the SAR is less than the fetus. Similarly, again, the fetus had lower SAR than the mother, and the mother had hardly any change with pregnancy with SAR. Looking at a birdcage core, this is from London, Jeff Hand, looking at the SAR on the fetus again, the maximum local SAR on the fetus is 50% of that of the mother. So basically, it kind of looks good. The fetus gets less local SAR hotspots than the mother. So the RF distribution is such that it's sort of relatively uniform, and the fetus isn't getting particularly badly affected. So it's not sort of focusing in on the fetus. That's good news. Another study showing the same things, really. But that's not the whole story. So this is looking at how the RF is distributed in the fetus. But it kind of assumes normal heat loss mechanisms. If we say safe SAR levels, safe RF deposition levels are okay. So SAR levels have been defined for the adult. The question is, do they count for fetus? So the SAR levels have been defined, so this is the RF deposition levels, have been defined assuming that the adult goes in the scanner can lose heat. So we assume that they lose heat due to airflow, so magnets have airflow through them. We assume the person is not too big, so there's good airflow all around them. We assume that the air is dry, it's low humidity, so that they can sweat and lose heat that way. And we also are advised not to, in general, wrap people up in blankets. So all these mechanisms lead to good heat loss mechanisms from the adult. But now consider the fetus. So the fetus is lying there inside the mother's abdomen. And, of course, the mother acts rather like a tea cosy, keeping this baby insulated from the outside, so it cannot sweat off heat, it cannot lose heat by airflow. And, of course, it's not in a high, low humidity environment. That's probably not relevant. So heat loss mechanisms for the mother, we're told to keep the atmosphere at 20. We're meant to lose heat through the skin, through peripheral vasodilation and sweating. And we keep good door ventilation and no blankets. But in the fetus, the heat loss mechanisms are much more compromised. First of all, the external temperature is at 37 degrees C, so it can't lose heat by the normal processes. So normally, to lose heat from a cup of coffee, it's the temperature difference between the coffee and the surrounding room that leads to heat loss. In the case of the fetus, the temperature difference between the fetus and the surrounding environment is virtually nothing. Actually, the fetus is slightly hotter than the mother because it's got a slightly higher metabolic rate. You can lose heat by conduction and convection through the uterine wall, but that would be much less than it would be across the maternal skin because of the surrounding temperature, 37 degrees C. The main way you'll lose heat is by blood flow through the placenta, so transfer of heat from the placenta, from the fetal blood to maternal blood in the placenta. But the problem with that is, of course, the maternal blood's at 37 degrees C, so it's still only a small temperature gradient to cause heat to flow from the fetus to the mother. And there is a temperature gradient, because as I said, the metabolic rate of the fetus is twice that of the mother, so there is some temperature gradient of about 0.5 degree C. But it's not as much as the 37 to 20 degrees C temperature gradient for the mother to the outside world. And actually, things are made slightly worse, because in the umbilical cord, where the arteries and veins are wrapped around each other, the heat will transfer back from the artery to the veins, and then the heat loss is compromised. You have to worry, really, as to when you put this heat into the fetus, can it lose it as well as the mother can? And I'm really pleased to say that Jeff Hand at Imperial did a study to work this out recently, where he did a heat deposition study, modelling, where he then took account of heat loss mechanisms to try and calculate the temperature rise of the fetus. So not just the SAR deposition, but the temperature rise. And he showed that if you're stuck at less than 2 watts per kilogram to a normal operating mode, if you reduce exposure for 6 minutes, everything's okay, to cut the long story short. If you go to 7.5 minutes, you start to potentially get a temperature rise to 38 degrees C. Now I have to say, this is all based on physical modelling. None of this is done through measurements, this is all done on maths. And so there's room for error here, room for error both ways. For a start, it doesn't take account of fetal motion, which of course will stir things up and increase heat loss. So this is a probably conservative point of view, but it certainly means we're on the edge. And other sort of back-of-the-envelope calculations also suggest that we're on the edge, but we have to sort of be careful here. We don't want to be exposing people above 2 watts. So we need to consider RF heating, and we need to note that the fetus is particularly sensitive to heating. 2 degrees C temperature rise is a teratogen, particularly in the nervous system. And of course, an additional problem is that the fetal imaging sequences we use have to be fast. And so that usually means that we use high SAR sequences such as HASTE. So we're actually using particularly high power sequences in fetal imaging. But I talked about the previous data being mathematical modelling. There has been one study, or probably a couple of studies actually, quite old studies with fibre optic probes in the pregnant uterus of a pig, and they haven't found a temperature rise. But I think that is quite old data, so it probably needs to be repeated now. So what can we do to avoid this? Well, certainly in Nottingham we stayed below 2 watts per kilogram, and I think it would be quite hard to justify going above it at the current moment. We maximise mother's heat loss. I say Nottingham, I should say Nottingham MR Centre. In the research environment, it's slightly different. We minimise the use of high SAR sequences, but you need to use them to get good image quality. And we try to arrange image protocols as far as possible to not do all the high SAR sequences together, at least ideally. So if you mix up the survey scans, the HASTE scans, the FIS scans, the DTI, the EPI scan, then you're going to have an area of time period where there's low SAR, low power deposition, interleaved with periods of high power deposition. So there are things you can do to mitigate heat deposition. Okay, so now moving on to gradient switching. So the gradient switch in an MR scanner, and this is the thing that causes peripheral nerve stimulation. So I don't know how many people experience peripheral nerve stimulation. You usually need to be quite big to experience it, and you experience it as a kind of twitching. I have to be honest, I haven't experienced it before, but you experience it as a kind of twitching on your shoulder or across your back. And the reason you do experience this is because this is the magnetic field gradient across the bore of the magnet. And as you do your imaging, you switch this gradient on and off. So now what we're doing is we're changing the magnetic field over here at the edge of the mother by a large amount. So we've got a large change in magnetic field, which is dB by dt, which is the sort of key thing. A large change in magnetic field will induce large currents in the body. But the key thing is that this change in magnetic field is biggest at the edge of the field of view because it's a gradient. So we get big change in the magnetic field at the edge of the field of view. So the first thing is that the big change in the magnetic field at the edge, so the mother rather than the fetus is exposed to the biggest change in the magnetic field. But also the key factor in inducing currents is the flux cut. So again, going back to early physics, you need to have a coil of wire to produce a current if you move something in the magnetic field. If you have a coil like a dynamo in the magnetic field, you've got a bigger coil, you get a bigger current in the magnetic field. So in this case, where we've got the whole uterine sac here, and the magnetic field going through it, we'll get a large field enclosed by the whole mother, but actually a rather relatively small field enclosed by the fetal brain. So to cut a long story short, the fetus is protected from PNS and things like this, peripheral nerve stimulation. The peripheral nerve stimulation, if it was going to be experienced, would be experienced by the mother. But to be honest, you probably would have to work quite hard to get it anyhow in a fetus, in a maternal imaging sequence. So that's the NMR fields, and so my summary would be, I wouldn't be too worried about SAR, about static field or gradient fields, but I would think quite hard about RF fields when planning imaging sequences. The next thing we have to think about with the gradients really is the effect of acoustic noise. Everybody knows that MR is noisy. And in the mother, the main method of transmission to the sound to the mother is through the air. So she wears headphones, and we have absorptive materials built into the bore and hopefully built into the room. And all these things act to reduce the sound within the magnet. They have ear defenders and earplugs, which hopefully make them happy. And also, of course, there's other sound transmission, not just through the air, but through the bore of the magnet, so vibration through their head. So you have foam padding to protect their head from the sound. The situation is different for the fetus, and it's a positive situation for the fetus. The fetus is inside the mother's abdomen, and its ear is filled with fluid. And in the adult, this air cavity here and the bones within the ear act to magnify the sound. But as soon as you fill this whole area with fluid, you can no longer hear properly. And so if in the fetus, the air is filled with fluid, which prevents normal transmission of sound across the ear. So that, first of all, protects the fetus' ear somewhat. Also, of course, the mother's abdomen itself is absorbing, and there's fluid within the abdomen which is absorbing. So we did a study looking at the intensity level of sound within the stomach, a fluid-filled stomach, using a hydrophone, and measured the sound level within the stomach compared to the airborne sound. And if you do that, you find there's about, probably about 30 degrees of sound attenuation right across the spectrum, which exceeds the effects of the headphones. There has been another study looking at this in labour, where I think their results weren't quite as reassuring as ours, where they found some amplification of low-frequency sound. So sound is a really difficult thing to deal with physically. Some frequencies will be enhanced in certain environments, and some will be reduced because of echoes and how the echoes set up resonances. They seem to find some resonance effects in the labouring uterus, at least, at low frequencies, not that far off the frequencies we use with MRI. And they found a gradual increase in attenuation for increasing frequencies up to about 4 kHz, which is getting quite high for MRI. So I think there's still room for some conserved acoustic noise. One way to reduce the acoustic noise to the pregnant woman, to the fetus in the pregnant woman, is to make sure there's good foam between the mother and the magnet bed, because the magnet bed is going to be the main source of transmission to the fetus, with sound coming up from vibrations. This isn't always possible or easy if you're using the wraparound surface coils, but it would be ideal. So of course, again, we use fast imaging to reduce fetal motion, and fast imaging sequences use rapidly switched gradients, which cause increased noise. So one way to reduce it is to use the sort of equivalent of soft tone, or whatever your manufacturer uses, to reduce noise, but that will always lengthen the sequences, so it's probably not practical. Again, reduce the image and duty cycle, or reduce the resolution. But all these things will reduce image quality. It might be better just to do it quickly and get them out. Possibly the most important practical thing to do with imaging fetuses, and I'm sure everybody in this room probably knows it, is intercable compression, and I'm sure we've all come across it when scanning. Basically, if you lie pregnant on a woman on the back, she doesn't like it. You should tip them to their left-hand side, because otherwise their vena cava gets compressed. They feel sick, get sweaty, get shocked. And so basically, when pushing them in, as far as possible, lie them on their left. Actually, I have to be honest, I swapped this picture over. This is actually a picture of someone lying on their right. It doesn't really matter if they're on the right or left, but ideally on their left. You can do fetal monitoring to check the heart rate during the scanning, if I guess the baby is already sick. We've used the CTG system that was made to be MR compatible. We did require changes to the design of it to make it safe to use in an MR environment, so that it didn't pick up the RF coil, pick up the RF power to induce heating in the mother, and also to make the Doppler ultrasound signals detectable. So we need to make sure there's no RF excitation to the ultrasound. We don't get ultrasound at RF frequencies either, and no RF heating. And then you need to do quite a lot of work to filter it. But anyhow, it is possible to do it, and I believe actually we did this for fetal monitoring, but I believe somebody's using it for fetal behavioural studies at the moment. Right. Finally, of course, you just have to consider normal MR terminology. Now, I apologise to say this in this room because I know everybody here are experts, but I really want to reiterate these facts. We're talking about scanning anybody really, but particularly pregnant women. You have to just consider the normal things that can go wrong. You have to consider acoustic noise. We must make sure the mothers have got earplugs. And I should say the reason I'm kind of doing this little bit of a lecture at this point is because I do a lot on MR safety, people write to me and ring me up, and it's sort of, I'm proud of doing MR. It's kind of upsetting when people ring with sort of sob stories of things that happen to them. So if you give people headphones, earplugs, they won't think they've got tinnitus off your scanner, whether or not they have. If you've got people going to the scanner room, of course, if you're scanning pregnant women, you might have husbands and partners and mothers and fathers all that around. All the normal screening is really important, and of course everybody in this room knows it. Something you may not know, and I've only just discovered it really recently from reviewing an abstract, is that, of course, clothing can give you burns, zips, all that sort of stuff, but clothing like sports clothing that has metallic strips in it, you may not notice the metallic threads. There's been a story recently of something like that setting fire in an MR scanner. The metallic strip picked up the RF, presumably the person was sweating, there's enough conduction to cause heating, and then it caught fire. So probably people should be put into Gowland routinely. And of course, potentially relevant with scanning pregnant women, obese people, or anybody to be honest, touching the sides of the magnets can get burns. Now we don't have a lot of problems with, again, in our research environment, even in scanning diabetic mothers, with them being too large to go in the magnet, obese mothers. It seems that being obese plus being full-term pregnant doesn't seem to be sort of limiting factor. I'm sure the clinicians here can say more about that. But once you're large and you're touching the side of the magnet, there is the risk of burns. Now, if I brought a radio in here and tried to tune it to capital FM or whatever it is, it wouldn't tune in immediately, okay? It would take me several attempts of moving the aerial and so on to get it to tune in. And it's the same with RF heating. You can put somebody in the magnet 100 times in the same way and nothing will happen. And on the 101st time, that loop will tune in and they'll get burnt. And we don't want that. So you have to do all the normal things as well to prevent burning. I know everybody in this room knows it, but please make sure everybody else does. So in summary, static fields, I don't believe, are a problem for reasonable exposures. RF does need to be considered carefully. I'm not saying it's dangerous, I just think you have to be careful not to do really high power sequences for long periods of time. Gradients, I don't think is a problem, except potential acoustic noise. And this would depend on the scanner. Again, it would be a bit like this, the RF. You can tune into it if you're not careful. Positioning is definitely not a potential problem, it's a real problem. And I'd like to thank quite a few people for helping me to slide with this. Thank you.
What's the current status of contrast what's the sort of appropriate advice as to whether, if you're really struggling in terms of...
I think given the, again, I'm not a doctor, okay, I'm a physicist, but given the work on NSF, we know the contrast crosses the placenta. We know it's in amniotic fluid. I mean, I guess I should leave it to you to compliment, but I wouldn't think it's a good idea.
We certainly haven't used it, because even if you're doing it for the placenta, we did wonder about doing it for the placenta prior to delivery and do it quickly enough, but then you've got it in the breast milk. So whichever way round you do it, you've got a problem with that baby getting that contrast.
And what's the evidence that, I'm not thinking about breast milk, I think that's probably slightly different, but if you're MRing placentas at, let's say, 26, 28 weeks, what's actually the evidence that using something like GAD actually is detrimental?
It dechalates across the placenta, so it separates the safety bit that which you excrete it out, and that just recirculates. And what we don't know is what that recirculation in the fetus causes. And it's already in
so it's a theoretical risk, rather
than it's a different compound to what you give to an adult who gets rid of it and excretes it.
But I mean, it's a theoretical risk, but patients who have renal impairment are in a similar situation where they're exposed for longer because they're not excreting it, and they get sick, so, or at least with the wrong agents. So I think we tend to be worried about the fetus who can't excrete it. And there are other ways of looking at the placenta, as you can tell us.
It would be nice to give it.
We do. Because it makes such a difference in terms of placental imaging. But I think that's why I asked the question. Because I think the issue is the risk parts ratio, but as you say, the risk falls on two different people. We shouldn't use it routinely, but that's why I sort of asked the question.